next session on elevating women in the workforce, if we have our panelists come to the stage. At this time, we have Dr. Shirley Malcom, Dr. Roopa Dhatt, Gabriela Rojas, and Sarah Hendriks. I will start. Dr. Shirley Malcom is a senior advisor and director of ECHAlliance at the American Association for the Advancement of Science. In more than 45 years at AAAS, she has worked to improve the quality and increase access to education and careers in STEM, with 2 M's, including medicine for all. Dr. Malcom has served in a number of science policy positions, including the National Science Board, a policy-making body of the National Science Foundation, and President Clinton's Committee of Advisors on Science and Technology. Internationally, she is a leader in efforts to improve access of girls and women to education and careers in science and engineering. Dr. Malcom serves as co-chair of the Gender Advisory Board of the UN Commission on Science and Technology for Development and Gender Insight. And in 2003, Dr. Malcom received the Public Welfare Medal of the National Academy of Sciences, the highest award given by the Academy. Dr. Roopa Dhatt is an assistant professor of medicine at Georgetown University Medical Center and co-founder and former executive director of Women in Global Health, which is now active in more than 60 countries. Dr. Dhatt is a practicing physician and a global health leader internationally recognized for her work that focuses on closing leadership gaps, advancing workforce equity, and shaping policies that improve health outcomes for women. With over 15 years of experience spanning clinical care, health systems, and policy, Dr. Dhatt has advised governments and international organizations, co-chaired the World Health Organization's Gender Equity Hub on the health workforce, and served on the Scientific Advisory Board of the U.S. President's Emergency Plan for AIDS Relief. Her efforts have helped advance gender-responsive approaches to universal health coverage and pandemic preparedness. Gabriela, and that's just 2 of our panel. Gabriela Rojas is the founder and CEO of Reglas, a pioneering femtech company that is transforming the menopause experience for women across Latin America. She holds a Master of Law and a Master in Public Administration from Harvard University. A committed leader, she has served on the board for Abogados MX, the Harvard Mexico Foundation, and Femtech MX. A former columnist for El Economista for a decade, Gabriela has been recognized as one of Mexico's most influential lawyers, awarded globally for women's empowerment, and named a LinkedIn top voice. And then we also have Sarah Hendriks. She is the Director of Policy, Program, and Intergovernmental Division of UN Women, where she drives their global thought and practice leadership through cutting-edge policy analysis, strategic guidance to field programming, and intergovernmental support to normative advancements of gender equality. Since August of 2024, she has also served as the head of the Secretariat for the UN Secretary General, Gender Equality Acceleration Plan. She has over 2 decades of work across multi-stakeholder partners, including serving as the Director of Gender Equality, Global Growth, and Opportunity at the Gates Foundation and the Global Advisor on Gender Equality and HIV/AIDS at Plan International Canada. I would say need no introduction, but this is a stellar panel. We are super excited to have them talk about how we can transform institutional change in healthcare, in academia, in government, and in the corporate setting. And so with that, we will take a seat, and then we will have our... Okay. And we will start, let's start with you, Shirley, if you can just give us a bit of a background. Each of our panelists is going to start off by sharing their initial thoughts and what they do and the hill that they want us to start on. And so Shirley is our panelist provocateur.
Yeah, we have been charged with giving you 5 minutes of spiel about where we're coming from. And in my case, part of it, a little bit of it is personal, but most of it is about changing institutions. Week before last, I turned 79. And so, thank you. But I tell you that because I want you to understand that when someone enters college as a pre-med major in 1963, that as a black woman from Birmingham, Alabama, that essentially you are a unicorn. You are definitely not in any space that you would recognize. And I want to talk about that because of the things that I encountered at the time. Essentially, there was no one around, and the advice that I was given was that I was going to have to be better than the guys around me in order to get into med school. Because at that time, medical schools were running about 9-10% women, quotas on there, all kinds of discrimination, and people talked about it openly. Now, you fast forward to Title IX in 1972, and all of a sudden, women basically started to feel like maybe they had a chance, and so they started applying more to medical school. And between 1972 and today, women are the majority of those enrolled in medical education. So everything should be great, right? The problem is that you may be in medical school, you may become physicians, but the change is very slow in terms of becoming leadership. And that is one of the reasons that I wanted to talk about structural change. Because I can stand up all the programs in the world to make women better, but we have done that for decades. I went to AAAS in 1975, the first time, and was studying programs that had been undertaken to bring more women and people of color into these fields, into the science-based fields. And what I found was the orientation was on fixing us. There was nothing wrong with us. And so one of the things that I was able to learn over time, and because Irene mentioned, I think that my doctorate is in ecology. One of the things that I learned by studying ecology is the interactions within systems. And in this particular case, it's not about us being broken, it is about systems that are broken. And so even after I studied interventions for years and years and years, I always knew we needed to come back to structural change. Because right now we look at the situation, for example, you're over 50% of those who are enrolled, but women are only about 28% of medical school deans. And women's routes into deanships are very different from men's routes into deanships. And so we end up by looking at all the steps in between. And you see the data I have, the current positions, 18% of department chairs, 47% of associate deans, that's the ones who actually do the work, 52% of assistant deans, and they are underrepresented as heads of department centers and the units that are responsible for research and clinical delivery, corporate strategy, and policy. And they're overrepresented coming through pathways to leadership, through pathways of education, DEI, and mentoring. So guess what? You've got to go for structural change. And that was one of the, after we realized that in AAAS, we developed a program called ECHAlliance, which is based a lot on the UK program Athena Swan. But in our case, we look at it a little bit differently in the sense of we have a separate biomedical component to it because it is so complex. The biomedical side is very complex and very different, legally even. And the structures are different, which means you've got to go after different things. The basis of structural change is know where you are today. That's number one. Disaggregate data, disaggregate data, disaggregate data. Every position, you need to know who is in those positions by race and by sex and by gender identity and by every measure that you can unpack. because those are indicators of the root causes of those positions to be like they are. So disaggregate data, go through a process of reflection on those data and sense making. How did those numbers get to be what they are? And once you understand the processes, be able to disrupt those processes in the sense of putting forward action plans to do things differently. And so on that note, I will stop.
Well, thank you very much. Next, we'll have Dr. Dhatt. If you want to, I think there's a microphone in your chair.
Oh, okay. Oh, got it.
Oh, you got your own.
Yeah, we each get a mic. That's shared power. Well, Dr. Malcom, I really don't know what I'm supposed to do in my 5 minutes because you outlined exactly the issues that I've been working on for the past decade. I came at it at a different stage in my career. I am a physician. I am an internal medicine physician, and I've always been practicing clinical medicine. And it was in that last year of residency when I found myself looking at the field of medicine and asking myself, like, does this field have a place for me to shape it, influence it? Clearly, as a young person who had dedicated already a long pathway, educational pathway, it was obvious to me that in the field of health, women deliver it and men lead it. And I hope in a room like this, everyone knows the data. 70% of the health and care workforce are women. And if you focus in on the patient-facing roles, especially roles such as nurses, midwives, community health workers, it is going to be easily 90% women. And when you take a look at leadership, it's 25%. And I'm not going to have to make that case because Dr. Malcom has already made that case. What that particular reflection sparked in me, and not just me, but thousands of other women, is a global movement called Women in Global Health. We launched in 2015. I had the privilege to co-found it and lead it, and it's a catalytic force and continues to be an unstoppable force to really ensure that women from all different backgrounds are viewed and valued as leaders. Now, as that movement is continuing to grow, I've been thinking in my new role, I come back to academia and been thinking about the poly crisis that we're in and how do we actually continue to elevate women in the workplace. The research that we did at Women in Global Health talked about systems change, so fixing the systems, not the women. That should be our baseline. We talk about having a foundation of equality. So what does that look like in the current context where many of our institutions are being challenged, especially academic institutions, from talking about diversity, equity, inclusion. And I'm so grateful for Irene giving us the cue when we started joining this panel prep that we can talk about all of these issues from a strong justice lens, because that is needed. That is how we're going to have progress. Call it whatever you must, but the values must stay there, that to have a strong foundation of equality is grounded in fairness, equity, inclusion, using intersectionality. So, the third aspect of it is how do you actually achieve this? What it really takes to transform societies as not just the policies, but it's the social norms. And we know that is what's being contested. And at the workplace, we have a role and responsibility to model that behavior, to create that environment, to fight to create that fostering environment. And especially those of us in academic centers, we can have formal programs, but we can also do a lot in our informal way. But what I would say is that more important than what we do in our workplaces is how we as providers connect to our communities and continue to talk about these issues. So this is how we continue to transform norms. And then it comes down to accountability. We need to continue to measure the progress, but also measure the setbacks, even though there are challenges around that. As scientists, researchers, academics, those working in this field at intersections of civil society, we all have a role and responsibility to do these things. So that 4-action framework, you can find out more about it at Women in Global Health, at the World Health Organization website. Those things still remain the same, but what's new in the playbook? I think we need radical action, and we need to be comfortable to tell stories and activate and not be shying away. There's some of us that can lean in because we do have more power and privilege and we can take more risk, and there's many of us that are going to have to lean out but support from behind the scenes. But to advance this agenda, we need to continue to work on these issues. And for women particularly, there are 4 key issues that need to be on top of the agenda. First is about power, which is the leadership, which we've heard from Dr. Malcom. Until women are in powerful roles, both positional power, collective power, all of those roles, making decisions, we're still going to backslide on the women's health agenda across the board. The second area is pay. Pay inequities are wide in the health sector. It is one of the sectors with the widest gender pay gaps, and we know that there's work to be done. Half of what happens in the sector is unpaid, but there is also success and momentum. I was at a meeting earlier today for the CHIC Coalition, the Community Health Impact Coalition, and they were sharing how there's over 50 countries that have committed to professionalizing community health workers and starting to pay them. Of course, it's not equal pay, but it is a commitment and progress from where that agenda was about a decade ago. The third is the issue of violence. Violence is growing in our societies all around the world, and that violence is coming in many forms. It is very present in online. The technology is going so fast with AI. We all need to learn AI, and not just to write our presentations and emails, but really how to effectively use it and create counter tools to protect the communities and protect ourselves. Violence comes as sexual harassment in the health sector. It is growing significantly high. The hospital I work at, we look at the numbers monthly. I'm part of a violence committee there, and we are seeing the numbers doubling and tripling from last year. And majority of that violence is, again, between patients and their healthcare providers, often nurses. And the fourth area is around supporting our health and care workforce and all health workers with their mental health and their psychosocial health, and recognizing women particularly will have multiple hats. I talk about at least 3, so the workplace, what they're doing in their home, whether it's for their children or parents or other care responsibilities, and what they do in their communities. We must recognize that and continue to work across the board on these issues. But let's be bolder. Let's upskill, and let's really do radical action to address this issue. Thank you.
And next, we will go into the corporate place and have Gabriela.
Thank you. Well, I don't know what I'm going to say after Shirley and Roopa, but I want to start with our reality check. So, women make up nearly half of the workforce. And one of the main disruptors that has been invisibilized historically is menopause. And menopause, together with, for example, discrimination, microaggressions, and also an increase in caregiving responsibilities at this stage, has been driving the women out of the workforce. In Mexico, for example, the main reason why women are out of the workforce, aged 45 to 54, is voluntary resignation. So women are voluntarily resigning their jobs at this stage, more than in the 30s, and double the rate of men at this same age. And this has a huge cost for everybody, for the women, in terms of income and in terms of being a productive member of their communities, of their families, of course, because it affects their families. The organizations and companies in which they work also lose. They lose in terms of talent. They lose in terms of absenteeism, presenteeism, turnover, loss of productivity. And if the companies and the businesses lose also, then the economy loses and the society loses, right? So what are we going to do with this? The good thing is that the solutions cost less than the problem. And it's an issue of rights, fairness, equity, but it's also a business case. And when I talk to companies and organizations and the public health system, I have to put it in terms of business, not only in terms of rights. Even if I'm a lawyer and I like to put it in terms of rights, if we do not put it in terms of business, as a business case, and in terms of economics, as a sound economic investment, it's very difficult to implement changes. But what we do have to do is to transform the workplaces for all women, attending their needs, their health needs and their realities across their life cycle. Not only during maternity for the women that decide to have children, but for women in all life stages, including menopause also, because as you know, for example, in Latin America is the region that is has the quicker aging workforce and population. And if we don't start attending this issue, we will have a problem as, for example, the UK or Italy or France already have. So what can we do? And that's, I think, the main question. And I think Shirley and Roopa have already touched upon this. We have to create a system change. We cannot do it one by one. Because to elevate women, we have to change the workforce and adapt the workplace to the needs and realities of all women, not only of some women, but all women. What can we do? Well, first, we have to normalize the conversation about menopause. Historically, it has been visibilized and it is stigmatized, and there's shame associated with this, so we don't talk about this. We have to change also perceptions, attitudes, and behaviors in the workplace associated with menopause. We have to eliminate discrimination and microaggressions in the workplace. It's incredible, but we do surveys in companies across Mexico, and we still find these microaggressions and discriminations in the workplace, even in 2025. And then what else can we do? We have to support women at this stage and support them in their needs as caregivers. So a caregiving system, we need that. We cannot go, we will not be able to elevate women in the workforce without having this caregiving system for all of us, not only for the women, for all of us. And I think, I mean, in Mexico, at least, we're starting to talk about it, but I don't know how we're going to fund it, which is the big question also. But I think that's one of the main things that we have to do. Women invest double the time of men in Mexico, at least, and similar patterns are in other parts of the world. So we need to take care of the caregiving system. And finally, we need to attend to women's health needs. Right now, women are bearing most of the cost. We know that women live longer, but spend 9 years in poor health, 25% more than men. And this gap is equivalent to 75 million years of poor health or life lost, premature death. And 1/3 of this can be explained by menopause and other sexual and reproductive conditions related to this. So this is an area that we really have to attend in the workforce if we want to elevate women. And finally, if the future of work has to do with adapting and transforming the workplace for all women across life cycles.
Thank you. And so now we'll have Sarah.
Thank you so much. What amazing contributions, insights, analysis, data. I've come here straight off the subway from the UN General Assembly, large gathering room where 167 governments, heads of state, heads of government, ministers from all over the world were gathered to advance commitments to the Beijing Declaration and Platform for Action, that transformative, normative agreement that came out 30 years ago, but that is still very relevant today. And indeed, the 70% of the global health workforce that are women are a critical part of the dialogue that's happening in that room. And in fact, as we bring a political lens to this, what we see is that only 30% right now today of all health ministers are women. Only 30%, actually it's under 30%. In fact, that figure has moved just in the past 3 years from 24 to 27%. Only 3% movement in 3 years. That, I think, is a leadership crisis when we look at this also from political promises. And the promises are very clear. The promises aren't just in the Beijing Declaration and Platform for Action, but they're also in the 2030 Agenda. And they're in other normative agreements that governments make. The Convention on the Elimination of All Forms of Discrimination Against Women just last year agreed to something called General Recommendation 40, all about the absence of women in decision-making, the absence of women in leadership, including in the health sector, and naming this for what it is, which is a significant human rights violation. And so we've discussed the data. We've also discussed, I think, the business case. We've discussed this as a rights violation, but the evidence is also undeniable that when it's not just an issue of representation, it's also about results. It's about what women bring in the global health force that is differentiated. And I brought a couple of data points that I'm sure this whole room knows. But we have seen that in the US, older patients treated by female physicians had lower mortality and readmission rates. We've seen in India, districts in local governments saw lower neonatal mortality rates thanks to stronger support for health services when there were more women in local governance. So we do see this criticality of leadership and the importance of leadership as a retention strategy as well. We're facing, I think, as already has been said, a shortfall of 18 million health workers before 2030, and we see women leaving, not because of a lack of passion or commitment, but also because of a lack of opportunity and because of a strong glass ceiling that they see in front of them. And when we add to this the challenge of unpaid care and domestic work, these challenges become quite personal. 3 extra hours every day compared to men. And globally, those data statistics are differentiated according to regions, according to countries. The reality that nearly half of women's contributions to global health remains unpaid, a point I think that Dr. Dhatt pointed to as well, is, I think, it takes great impact on community health and community health service provision. This is, I think, not just an altruism of women health workers' unpaid status, but it is, in fact, also exploitation. So we want to, and I think, need to look at what change looks like. And there have been, I think, very clear perspectives that have already been provided by the panelists. So as I close out and as we go into the Q&A, perhaps I can leave you just with an additional 4 ideas on how, when women lead in health, that the ripple effects are stronger, that the implications for not just lives saved, but also for the health of communities, of societies, and of even countries and their economies becomes more equal and more resilient. So number 1, we feel there's a strong role for governments to play in terms of implementing policies that take seriously the imperative of women's leadership. Number 2, that there's a critical role for health institutions. I think Dr. Malcom pointed to the imperative of data and the disaggregation of data, of bringing that intersectionality lens. And here, health institutions must track, must report on that disaggregation of data, particularly from a leadership perspective. Number 3, we deal with donors all the time. I know all of you do as well. Donors and partners need to fund women's leadership programs to bring that funnel of new leaders in women's health, in women's global health, up to the forefront of priorities. And number 4, as has been already raised, we need to challenge the biases, whether those are subtle or where they're more direct, whether they are microaggressions, as Gabriela has pointed to in the workplace, or whether they are intrinsic to systems and structures that Dr. Malcom and Dr. Dhatt have pointed to. But we need to look at those deeply rooted biases and the ways in which norms are reinforcing the inequalities as well as the lower value of women, and transform that once and for all. Thank you.
I want to start off the discussion with a comment and something, and I'll rephrase. We were in a different program in talking about menopause in the workplace, but it supersedes menopause. The question I'm about to ask, that sometimes we had different movements for women's rights. We're now in the workplace, and some would say, we asked to be here, and now we need concessions. How do we shift the narrative that it's a liability, or that it's too much work, or we shouldn't have to do this in our workplace settings across the board? How do we shift that liability in recognizing that it's a value add in a potential loss? How do we do that?
Can I start? I want to start because
It's automatically.
I want to start with menopause. Okay. Those are women, some of women's most productive career years. And if we aren't able to take advantage of what they understand, know, and are able to do at that point, we have a problem. I do kind of resent the idea that I've got to do a business case. I think that morally this needs to happen. Okay, I was in Beijing, and I was at that conference, and I was with those women, and I, in fact, believe that we're talking about human rights issues. Now, that said, I can make you a very strong business case. Around issues of productivity, I can make you a very strong business case around issues of family thriving, community thriving, institution thriving. Retention of valued personnel within institutions. All kinds of bad things happen when you don't pay attention to the folks who are around you and to their well-being. And that is what I think that we have to really focus on. That's one of the things that I like about the Sea Change Biomedicine. It essentially goes through the entirety of the organizational structure and asks questions that institutions are supposed to ask themselves. Not that we want to know in Sea Change, but that the institutions need to know about pay equity, about how long people are in grade, men as opposed to women, about the differences that they are actually experiencing in terms of their of mobility, and all of the ways. There are lots of different ways to discriminate. And that's one of the things that going through that kind of exercise can begin to unveil. It can basically lift the veil right now of that kind of keeps us begging for. We keep begging for attention and awareness and change. And I think we've got to move from that to helping people understand that it is in all of our best interest to make these changes. You're not doing something for women. You're basically doing something for society, for families, for institutions. And I think we have to be unapologetic about it. So when you put systems in place and you uncover inequities, what is your response to the inequities you uncover? That's the question. That is the question. If you find that there's a difference in pay, what do you do about it? Actually, it's illegal to just let it sit there. I mean, I think that there are these kinds of things that we really need to look at and help institutions go through the process of self-reflection and self-examination to get beyond where we are to where we all need to be.
All right. So, and then I do want to follow up as we see these changes, and this is for anyone on the panel, how do we make sure we can break the cycle? We see iterative change, even as you mentioned, Sarah. It's like very small here or there, or we even see, I think earlier today, Dr. Kaida, when she put up some data, we didn't see that there was much change, or we've actually regressed in some ways. How do we break that cycle with the work that we're doing?
Yeah, I think this is where we have to get to the hearts of people and hearts of people across generations. I do think that there are a lot of things we learned from the pandemic, and we don't necessarily take the moment to talk about it because, of course, there's PTSD for all of us in society. But it put a spotlight on a lot of the inequities that exist, especially in the healthcare system. But, you know, during that time, and especially in this city and many other cities around the world, everyday people were applauding the nurses, the doctors, all the healthcare providers. They were lighting candles for them. They were honoring them. And we had this like tagline that we said, you know, we must turn that, you know, applause into action. And at that point in time, society really saw our health workers as the heroes of society. And you know, we have to, you know, capture those moments. We don't always capture them and turn them into action and investments. But I think there's really something in the power of stories of what we carry as health workers, telling our stories not just as superheroes, but our vulnerabilities. We need to convert hearts. And the second aspect of it is intergenerational. A lot gets lost every generation. As I'm sitting next to Dr. Malcom, I have to call you Dr. Malcom. I know you said Shirley, but just, you know, I feel power and energy just being next to you, knowing that you went to Beijing 30 plus. I didn't, but I was one of the advocates at the 25th anniversary, and I continue to be an advocate for that agenda. But so much gets lost because every generation tries to go at it, and they should go at those problems. But what can we do to have this intergenerational transfer of knowledge and continue to inspire each other? The third is, what do we really mean when we say we want to be an unstoppable force or we're going to do radical change? What does like solidarity in the community look like? I think too often we allow ourselves to be divided and conquered instead of having a true common agenda on equity and bringing everybody forward together and being not compromising about it. And that takes deeper thought. It takes more than window dressing. It takes being prepared in a wiser way. I think I hope the other panelists build on this. But we also need legal protections, and I think that's where UN Women and the United Nations has really given us models about how quotas make a difference, how using legal instruments, things that we may not be as familiar with in the medicine field, how we can use those tools to create protections, but then also to be backed by resources, donors, private philanthropy, individuals giving a little bit so we can create funds to not only innovate, but also to protect the rights that we've gained and support women's movements and grassroots communities.
Just to maybe naturally build on this point, couldn't agree more. And what we see with governments around the world, that one of the most significant and effective tools to increase women's leadership in political governance is temporary special measures, or are temporary special measures. Now, temporary special measures are the utilization of legal quotas that have advanced and really upturned women's representation in local governance, have more than doubled women's representation in parliaments since Dr. Malcom was in Beijing. And now we have some movement at the head of state, head of government level, but still 105 governments around the world have never had a female head of state or head of government. these types of tools can be applied to this context and should be. But we also know that leadership is also a retention issue in any workforce, including in the global health workforce. And so part of that is also that women aren't necessarily being effectively included in the decisions that impact their workplace, their patients, their lives, their well-being, and their livelihoods. And so enabling and working together with leadership that values women's perspectives, that lifts those up, that values their expertise, and that creates decent working conditions to reinforce retention is also such a critical avenue for change. I think here, I was struck by your points, Dr. Malcom, that it's not a business case. It is fundamentally a right for women to lead. And women already are leading in global health. And so how do we ensure that that leadership, which is there, is lifted up and moves from the periphery to become the norm and to become recognized ubiquitously? Thanks.
Well, me being a lawyer and believing that it is a right and that we have to look at it from this perspective of rights, I have to insist in my conversations with government, with the health system, with organizations and businesses and companies, it doesn't work. It doesn't work. We have to come also from the business side in terms of why is this a good investment? And we know that if we invest $1 in women's health, we get $3 in return of investment, social investment, and social return on investment, sorry. And we know that if we have a diverse workforce, it's going to be more collaborative, more creative. It's going to be it's a higher probability that the businesses and the companies will get to their operational. I forgot the word in English. Metas, their goals, their business goals, and just do the math in terms, for example, of investment from the public health system. If you invest in, for example, menopause or maternity mortality, or you're gonna reduce your costs long-term in diabetes, cardiovascular events, anxiety, depression. But if you do not do the math, it's very difficult to convince policymakers. Even if I agree that it has to come from rights, it's a right issue and an equity issue and a fairness issue and a justice issue. But we have to come with both arguments, because if not, it's really difficult to convince them to invest in these issues in the workplace and also in the health system. And the other thing that you touched upon, Shirley, one of the many things, is data. We don't have the data. We don't have the data to measure our advancements in these types of policies. When you talk to companies and organizations, they don't have the data on, for example, why women are leaving the workforce. No, they don't have the data on how absenteeism or presenteeism is affecting their workforce in their workplace. So it's really difficult to create solutions that are targeted to specific problems, because we don't actually lack research on the problem itself, and we lack data. And for example, in the public sector, the same thing. In Mexico, I think we know more probably in the UK, in the US, in Canada, for example, but not that in other Latin American countries, where we lack basic data on how women live through menopause, how much it costs for women, and all that. So I think one of the things that we really do need is more research, more data, and as you were saying, like measure everything so that we can understand the problem better.
I hear you. I hear you, but I want to just share something that a friend of mine once told me. And that is, you don't just need stats, you need stories.
Yes. Yeah.
That, because quite frankly, they will listen to your story, and that's the reason that they will stay for your stats. They're not going to do it the other way around. And so, and there are some for whom evidence seems not to matter. So you've got to throw everything out there.
And I was going to build on that. I said link to action. I mean, the way that our health systems have changed is when we protest, when we create unions, when we, it takes collective action at multiple levels. And I think when collective action is effective is when you have all the other ingredients. And I think each one of us are emphasizing different one of those ingredients. But I would like to emphasize that the only way we're going to elevate women in the workforce is if there is truly a transformation and redistribution of power, and women are at the center of it. And women will uplift not just girls and women, they're going to uplift everyone. We lead differently, and we have all the evidence for it, and now it's really time to continue to take actions. I don't want to at all downplay how much action has already gone in, how much sacrifice, how many of us that have been part of women's movements are feeling exhausted and need to be refueled, but that is the fight. And I would say, especially in academia, we often don't think about ourselves as advocates and activists, but guess what? That changes in our house, and we need to be inside activists in our institutions. Thank you.
If I can just build on that point, if that's okay?
Sure.
Yeah. Data, quant, stories, action, but if I could add the word accountability. Because I think accountability needs to be much more than symbolic. We need to ensure that accountability to action is really met and measured. And we see this all the time, obviously, in the UN system and in our work with governments. We need mechanisms that track progress, that enforce accountability, that actually tie leadership metrics to performance on lifting up women in leadership, that tie funding to the metrics of lifting up women in leadership, because it is the right thing to do, because it is a right, because it drives results. So gender equality in leadership needs to be that measurable outcome that all see as a transformative one, and that all are held accountable to achieve.
No, that's fine. We have a question that fielding.
Thanks. Thank you for this very elegant discussion. My name is Komal Bajaj. I'm an OBGYN, and I serve as a chief quality officer within New York City Health and Hospitals, which is the municipal health system for New York City. We take care of millions of New Yorkers every year. I wanted to double down on this measure and structural change conversation by a quick vignette and then a question. Recognizing that there is structural bias and injustice everywhere, we've incorporated an equity lens into all of our performance improvement initiatives, whether it's decreasing infections, workplace violence, improving diabetes rates, newborn screening, you name it. And what we found is that across now hundreds and hundreds of initiatives over many years, 1 in 5 projects which are completed, meaning they met their aim, have an intervention-generated disparity, which we wouldn't have found if we didn't stratify the data and look for it, right? And as a result, we've been able to really design additional tests of change to close that gap. And so the question for the group is, Gabriela, you started by talking about some of the measures that you wish existed. And I wanted to just kind of double down on that. If you could, press an easy button, wave a magic wand, what would be some of the measures that you wish were tracked with, data integrity? Or what are some of the existing measures that you wish were stratified and shared publicly?
Thank you for the question. I think many of the measures have not been stratified, as you were saying, by gender, for example, or by age. Talking specifically of menopause. So, for example, terms of absenteeism, productivity, presenteeism, turnover, resignation. And the causes for resignation, because in terms of causes for resignation, this is a tricky one, because there's, at least in Mexico and other countries that I know the data, for example, 8 out of 10 people little or nothing about menopause in the case of menopause. So even if you were to ask about it, and since it's also a taboo, maybe women would not even answer that they're leaving the workforce because of menopause. Maybe they would say health issues, migraines, or something relative to one of the symptoms of menopause, but not precisely menopause, either because it's a taboo or because of a lack of knowledge. So that's the trickiest one, I would say. But if you then stratify it and be able to compare it by sex, by gender, by age, I think that would give us a lot of information to see why women are leaving the workforce and the reasons behind it and the reasons why they're not going to work, or they're going to work but they're sick and they're still going to work, but their productivity is diminished, for example. So in terms of workforce and menopause, I would use those.
Let me just say a couple of things here, and that is that I heard the issue of accountability, measure, etc. When you collect the data, you don't just collect them. You have to make sense out of them. And the sense making really goes to trying to determine root cause. What is actually causing the data that you see? The thing that you want to accomplish is that everybody have a good work environment. This is not a women's issue. This is that everybody have a good work environment. Usually the one who isn't is the woman, but the purpose is for everybody to have a good work environment. What we have done in ECHAlliance, which I think makes it unique, is that an institution basically tells us their story. This is what we found when we collected our data. We don't want to see the data because oftentimes the cell sizes are just too small. The level of disaggregation you need in order to really figure out where your problems are. But you tell your story, and then you say what you're going to do about the things you found, and that you have discussed internally with change teams, because you need to build a community of that goes along with the idea of making change in order to really make change. But after that, when they come to us, it goes into peer review. People who hold similar positions elsewhere look at these plans and they make comments they give feedback on the plans. This is external, because in a lot of cases, internally you'll give yourself a pass, but externally you won't. And so you have external peer review with feedback and comment. But in this, we have built in a structure of increasing recognition, the same way that they had like LEED certification, the same way they had with the Athena Swan. That is, you start with a bronze. You can go to silver if 5 years from now you have made progress. That's an accountability system, but it's a different kind of accountability system. And it is one that I think we're going to have to rely on private recognition systems for a while, because I do not see government accountability structures basically clicking into place anytime soon. But we've got to do workarounds that support the excellence and quality of our community. This is our community, and we've got to fix it.
So we actually do have a hard stop because we have panelists that have to leave. So we will field questions later, but I just wanted them to give their final thoughts. And so we can go, Roopa, on down. Very brief, 1 or 2 sentences to close us out.
Yeah, so it's been a privilege to be on this panel. I would say let's continue to push forward with collective action and leverage each other's different networks and ensure that everyone's taken care of, and especially the women in the workforce. And that's how we're going to achieve the women's health agenda, but I would say even more than women's health agenda, we're going to achieve universal health coverage.
Did you have?
Oh, I've had my say.
I think from a global lens, I would say just a reinforcement of how important it is to grapple with the structural barriers that constrain and inhibit women's leadership from growing and thriving. And those barriers are multifaceted. They have to do with equal pay, but they also have to do with unpaid care work. They have to do with experiences of discrimination in the workplace. They also have to do with the experiences of violence, both at work and in some cases at home. Our latest research shows that just last year around the world, 1 in every 8 women experienced sexual or physical violence from an intimate partner in her life. And so really grappling with some of those structural barriers in order to address them is a critical component, in addition to everything that we've discussed, to shift the calculus for women's leadership and health to thrive. Thank you.
I think we have to all come together to promote a systemic change, to adapt the workforce for every single person along all their life stages. And as Shirley was saying, it's not only for women, it's for all of us. The workplace was not created for all of us. It was created for some of us. So, but we need a system change. We need public policy. We need a huge partnership from the public, social, and private sectors. And we all have to come together to adapt the workplace for every single one of us.
I do have 2 sentences.
We know it's
Even though our program basically focuses on making change that supports all, we have had challenges with regard to institutions that feel as though they cannot remain in it. And it relates to the fact that there is a level of fear and trepidation among our institutions about trying to do things that lead to improvement for any group, even if it is all groups. And I think that this is disappointing, but it is also frightening, because what it means is that we will lose ground in our institutions. And what was beginning to be seen as intolerable, there is now space for it to reappear and to be seen again as normative.
Thank you so much for all of that. And I would say the 3 S's: we need stats, we need stories, and we need strategies. And then we have to come back around with that accountability. Thank you very much for joining us today with this panel. If you can have a round.